Unfortunately, Professor Steven Faux couldn't be here in person, but we're still delighted that you can make it with us online. So, Steven, welcome. Director of Rehabilitation, and so a slightly different slant is when we got COVID, we also had to face the fact that some people took longer to get over it than before, and this concept of long COVID crept its way into chronic fatigue and all of those other sort of post Epstein-Barr virus and all those proven, not proven, difficult areas. Steven stepped up to the challenge and written a lot about it. I've been talking about it, so it's with great pleasure that I welcome Professor Steven Faux to talk about long COVID and his work in that area. So, Steven, good morning and welcome.
Hi, thank you very much for inviting me. Thanks for having me. I wanted to have this opportunity to talk to you a little bit about long COVID. I just want to indicate that, all right, yes, I don't have any disclosures. I just want to talk a little bit about the pathway to a definition. This is the first illness that was noted on social media in the world, and it was noted by a neuroscientist who was suffering with it. The British and the Americans came up with sort of definitions, and then the WHO did. Australia follows the WHO definition. The first sort of set of definitions was called post-acute sequelae of COVID, and it covered those with persisting symptoms after hospitalisation. Long COVID, or PAS case definition, came out through the WHO, and it defined it as a diagnosis of exclusion, which I think is quite a headache for general practitioners. And then in September, the post-COVID-19 condition was defined, and an assumed rate of between 10 and 20% was indicated. In Australia, we have various rates, but most of those are based on the definition and which definition you choose, and also which population you look at. It was thought early on in the pandemic that was going to be around about between 0.5% and 4% of people who had COVID who'd have long COVID, and the later definitions the later assessments look like it's more like 10%. So there are three diagnostic criteria, and the first is that a patient must have had COVID or probable COVID. Now, that was okay when we were registering who got it, because they all had PCRs. Then when we went to RAT testing and personal responsibility, there was a lack of registration of positive RAT tests, and now we really don't know who has it. So when people come to you with a condition that might be a long COVID, you can run an antibody test, which is about 80% accurate up until 6 months after the illness. You're looking for nuclear capsid antibodies, and if they're positive, you've had a previous infection within the last 3 to 6 months. Spike proteins can be positive if there is immunization only. So what you're looking for is, if to diagnose a probable COVID infection, is a positive nuclear capsid antibody, irrespective of whether the spike protein is positive or negative. It should be positive. The patient has to have symptoms persisting for 3 months, which means from the time you get COVID, you've got to have ongoing symptoms for 3 months. But later, it was identified that the symptoms fluctuate. And if they do fluctuate, you've at least got to have them continuing for 2 months, because if they're fluctuating and they're not more than 2 months, then it's possible that all you're seeing is an unusual passage of recovery. There needs to be no other diagnostic explanation for the symptoms. Now, this is quite complex, particularly in older patients with a lot of degenerative conditions who have vague symptoms. I'm not going to tell general practitioners how to assess fatigue. That is definitely in the ballpark of general practice. But what you do have to be careful of is people with pre-existing fatigue conditions. And I've got a case review that shows one of those. I still do need to talk about it, because a lot of people wonder whether it's real or simply another post-viral syndrome. You've got to remember the history of this. Epilepsy was thought of as supernatural until we discovered electricity. And you've got to remember that the Spanish flu occurred before there was chronic illnesses. We didn't have insulin at that stage, and before social media. So we don't know, we can't use the Spanish flu as a comparison because we don't have a population of people with chronic illness. If you look at the illnesses that occurred post pandemic, or the post Spanish flu, such as TB and polio and HIV, all of them have chronic phases. And the question is, as clinicians, should we be lumpers or splitters? Well, that means, are you going to lump all viral illnesses, post-viral illnesses together, or are you going to split them up? And I suggest that splitting them up is a safer way. Otherwise, you won't miss Guillain-Barré and some other conditions that can occur and can be treated following a viral infection. So this virus is a bit different. Coronavirus we've seen before in SARS and MERS, and now in C19. And it certainly wasn't present at the time that chronic fatigue syndrome was initially described. There are a number of symptoms that sufferers have in common, the other thing about long COVID is that there's a handful of symptoms that have never been described, like anosmia, hair loss. And I think we need to acknowledge that most people with long COVID, or 91% of them, will recover over 2 years. Just want a quick word about the Queensland research. You may have read about this. The Queensland Chief Health Officer compared COVID-infected population with people who are infected with influenza. And he found that 3.6% of COVID patients and 3% of those with influenza had functional impairment at 12 months. That was a little bit mischievous because you can't really compare the two populations. COVID population was 90% vaccinated, and the influenza population was about 40% vaccinated. People who were hospitalised or in ICU were not included in the COVID group, and we know that they're more likely to develop long COVID. And the volume of populations wasn't considered. Like 3.6% of the 3 million Queenslanders who got COVID is about 144,000 people, which is more of an issue than the 2,500 people who get the long symptoms following flu. So the issue really didn't help to clarify things. So is it different from other illnesses characterized by fatigue? Well, dyspnea is its hallmark. There are radiological changes. We have some blood markers. Bed rest and comorbidities and obesity put people at higher risk. Steroids that are given to people in hospitals might actually increase some of the fatigue-related long symptoms. Many of them have PTSD and mental health problems from a pandemic that that had a high mortality rate. Anosmia, hair loss, is one of the things that characterises long COVID from others, and most people recover. That's based on Robineau's paper. When we look at similar viruses like SARS, fatigue persisted for 4 years, and women and those who were using steroids had longer fatigue and weakness. There were lung diffusion abnormalities lasting for 12 months with SARS. With MERS, there were persistent lung changes for 12 months. So it is a slightly different virus to others. If we think about polio, polio was actually where rehabilitation was born in Australia through Sister Kenny, a Queensland nurse, who suggested that children who had polio should be exercised. And that was quite a radical thought at that time. But what we found is in the sort of 90s and on, we had the late changes of polio, where people who had polio as children started to develop weakness, rapid weakness in their older ages. With TB, we had isolation, we increased ventilation, and we had rehabilitation teams in sanatoria. And again, that sort of emphasises the importance of ventilation droplet-borne illnesses. And with HIV, we had quite a strong public health approach for it because we were worried about the development of AIDS, which happened a little bit later after you had HIV. And then we now have some cognitive impairment, and we're now managing quite a large number with chronic HIV neurological illness. So COVID is not that different. It's an illness that we've all had, and there is currently a chronic phase that we're seeing for at least 2 years. So it really isn't that different. First step really in general practice is to validate the patient's symptoms. I don't need to tell general practitioners that, because you're experts in communications with patients, and we learn a lot from that. We do know that people don't want to give up work. A study by Lally that was just published showed that I think it was actually 9.3, that's my dyslexia playing up, sorry, $9.3 billion were lost since 2020 through work loss, which is 0.05% of gross national product. And I don't think people want to not be at work or lose money. I don't think they go for illness for that purpose. You have to take people as you find them. So vulnerable people with mental illness and complex social situations are more likely to have complex disease. And dismissing them or minimizing symptoms is often remembered. And when in our chronic long COVID clinic at St Vincent's, it's often what's reported. Somatoform disorders do occur occasionally in long COVID, but they're rare. They're a rare form of disease, and they're not the common presentation. So starting from that base that this is a somatoform disorder is probably not going to serve well. What are the main theories? I'll just go through this very quickly. Immune dysregulation is one of them, where the immune system continues to send out impaired signals to the T cells, and we find that this might be due to reservoirs of the virus being present. The microbiota changes, and we know that because people with long COVID secreting COVID fragments in their stool for up to 7 months. And we believe that this affects absorption of many amino acids, including L-tryptophan, which might explain why there's a high rate of cognitive impairment and depression. Sometimes there's autoimmune antibodies produced, and we're noticing that some people reactivate their IgGs or IgMs on Epstein-Barr virus or CMV despite not having the symptoms. And we also know that blood clotting has been a problem because some of the antibodies are against endothelial, which change the flow dynamics in blood vessels. And we do know that there's dysfunctional neurological signaling. Autopsy results showed that particularly the fifth cranial nerve, but also the vagus nerve, was teeming with the virus compared to other tissues in the body. So there's 200 common symptoms. So I'm not going to tell you how to cure all of them, but I will tell you that in our long COVID clinic, we're often seeing a lot of fatigue. We see cognitive impairment, shortness of breath, and fatigue and shortness of breath are probably the most common symptoms, so much so that we triage people to see the respiratory physicians with shortness of breath and the rehab physicians with fatigue or difficulty walking. But we also have unusual presentations. There's quite a lot of pain and headache, and we see palpitations. About 10% of our patients will have symptoms consistent with POTS, and the treatment for that is often requiring a beta blocker if their speed of their heart is very fast, or ivabradine, which is a medication that changes the variability of the heart rate. So this is what we use. It's called the Yorkshire C19. It can be it's available online and also available on the phone. It's being used by New South Wales Department of Health on the Hope platform, and it's easy to get access to and free. And this is given to the patient, so you don't have to fill it in. The patient fills it in, and if they fill it in the waiting room before they see you, you'll be able to not only help with the diagnosis and focus your history, you're also going to be able to monitor their recovery. So the models of care that were used in the UK, but also in Australia is firstly self-management. So there's a lot of websites that people can get access to understand how to run their own rehab show at home. There are state health pathways that advise people to see GPs as a second stage if their symptoms are persistent. Then there's in the UK, there's supported, coordinated specialist referral. So if, for instance, you think the person's having cardiac symptoms, you might refer them to a cardiologist, but often the cardiologist will just refer them back to you and say, there's no diagnosis here. And then you need to run a rehab project, a rehab program in the community. And then for people who've got very complex disease or are not settling down, referral to long COVID clinics is probably ideal, although there are very few of those and they're not funded widely by the government, not in New South Wales and less so in Queensland and Victoria, not in Tasmania, none in Northern Territory. There is one in South Australia funded by the public sector, but I think there's only private sector funding in WA. So the early multidisciplinary rehabilitation can prevent chronicity and improve outcomes. And one of the reasons is that generally you can trial medications, but you're trying to just improve a person's function while they're getting some recovery. So early supported discharge, it works in stroke. It works in geriatric. It works in geriatrics. It works in patients who've had ICU admissions, traumatic brain injury, spinal cord injury, and home-based rehab for deconditioning and frailty have improved clinical outcomes and independence, and have prevented hospital admissions. So in Australia, there's 19 clinics that have been reviewed in 2023. Only one, which I think is the St Vincent's one with specialist membership. Most are run by Allied Health, and some have GP involvement as well, particularly in the private sector. Those clinics are probably taking the burden of long COVID, as well as the general practitioner and their population as well. A lot of public clinics have been closed in Victoria and New South Wales, but are being reimagined at the moment. So early rehab in a systematic review, it's improved breathlessness, mobility, quality of life, and muscle strength. And that's just getting physiotherapy to teach people ways of managing breathlessness on exertion, and psychology teaching people how to pace themselves and not overexert themselves, which can lead to a post-exertional exacerbation of symptoms. So people have to pace themselves. There's been a Norwegian study where they did a 3-day intensive rehab program with telephone follow-up that had quite a good outcome. And we do know that a response to fatigue of lying in bed can be actually dangerous and cause other complications. So how do you do that in the community? Well, the government has indicated that long COVID is defined as a chronic illness, which means you don't have to wait 6 months before you can use mental health plans and extended care plans. And you need to assemble a team of physiotherapists, if you've got a physiotherapist or an exercise physiologist that you use, an occupational therapist if there are issues to do with work, and a psychologist, particularly if there's anxiety and depression, or in fact, if there's a problem with pacing, psychologists can help people who are anxious and having trouble to manage their pacing in amongst the pressures of work and looking after families, etc. You need to have an initial health case conference with your Allied Health and set some goals. You commence the multidisciplinary rehab program. You need to see the patient again between about 6 and 8 weeks and see to make sure that you're meeting the goals. And then at 12 weeks or at the completion of the program, and you might have to assist the patient in returning to work. So an overall plan, you need to also give advice of further testing, vaccination and cardiovascular risk. The evidence is within the first 12 months of a COVID infection, the rate of cardiovascular events increases. It's close to 50% more than usual. You've got to measure all your symptoms at the start, which is why the Yorkshire 19 is good. Then you've got to make a plan for treatment. Now, you need to have a movement program with a physio. They're very, the population with fatigue are very worried about graded exercise. And what that means is exercise physiologists or physios who put people on a sort of standard program of increasing their exercise without reviewing them and checking on their fatigue rates. So a movement program or an activity program is a better word to use because it teaches the physio to check in with the patient. Psychological advice I've talked about, occupational therapists you're aware of. Follow-up and further outcome measures. You can use the Borg scale, which is a physical scale for breathlessness, the Yorkshire 19 through the HOPE platform. And the other one that's very simple to use is a fatigue severity score. It's only 7 questions. So referrals to the other thing is those of you with access to public public hospitals that have rehabilitation medicine units can refer for post-COVID rehabilitation. Those of your patients with private health insurance have access to private rehabilitation centres for reconditioning rehabilitation following COVID, and the rehab physicians in your area should be able to see them. So that is an option that is available for you. Just to run through the things that do work and the things that don't, TENS and TMS and virtual reality are promoted, but there's not a lot of trials. There's one protocol paper that's been put in, but the actual trials yet to be put through. A lot of people want to use supplements. I guess supplements are not too risky unless they're in, ridiculous amounts. But all of these have been trialed, but there's little evidence to use that. There's a lot of hypothesis papers, but little evidence. So hyperbaric oxygen has been shown not to work. Off-label medication uses such as modafinil, which is a stimulant, antidepressants, L-DOPA, there's very low evidence, and trials currently are commencing in the US and UK. But if you use off-label use, this needs to be carefully considered. You need to consider the risks versus the benefits. You need to consider the costs versus the benefits. You must get consent of the patient to tell them that you're trialing a medication off-label, so it'd be important to note that. And if there are complications, you have to check your liability. I would suggest that the best thing to do if you wanted to do that is to use an experimental design with an outcome measure and an ABA pattern. You're responsible and need to annotate that this is part of a trial in your practice. You ask for consent. You clarify whether it's safe or expensive. And you decide on what the outcome measure might be. If it's fatigue, then you say, okay, I want you to do the fatigue severity scale. You get them to do it in your room. You ask them to use the drug for 2 weeks, then do the measure again, then stop using the drug for 2 weeks, do the measure again, and then start the drug again for 2 weeks and do the measure again, and then bring you the results. This way you'll know whether when the medication's used, you get improvement, and when it's not, you get deterioration. I think once you do that, that's a responsible way to trialing it. I want to caution you against some general practitioners in the United States have been using chemotherapeutic agents, and I think the risks are much too high for that population to use those. But we use, for example, we quite often use colchicine for chest pain and metformin sometimes. Metformin actually has been shown as to be preventative, and I'll talk about that in a moment. Here's a case study. Stephanie, 59-year-old real estate agent. She's got COVID in January. She's got a past history of myasthenia gravis, which was treated with a thymectomy, and she's not required medications or anything since that time. Since the COVID, she developed fatigue, cough, breathlessness, anosmia, brain fog, and now she's sort of slow at work. She gets a lot of errors. It's tingling on her face, and she's got an occasional foot drop, and she's quite distressed. MRI was normal, a MOCA was normal, and she started a resistance training program. So some of the best sort of exercise programs to do for fatigue are weights and not as much endurance work. So you do more weights and a little bit of endurance, and you get the physios to measure that. And she said she had palpitations when very fatigued. So the question is, would you commence a rehab program with a graded exercise program, or would you continue, would exclude cardiomyopathy with an echo? Would you commence treatment for anxiety? Would you check her anticholinesterase antibodies and MuSK antibodies for the myasthenia? Would you commence a rehab program with pacing and cognitive retraining? Or all of the above except for A? I think you know the answer. So what we did was we did all of the above. She was admitted. We did tilt tabling and a cardiac MRI and an echo to exclude myopathy and pulmonary hypertension. But her MuSK and anticholinesterase antibodies were extremely high and very different to levels done before COVID. And what seems to have occurred is that autoantibodies will reproduce following COVID. And so she required the commencement of Mastinon, which is the treatment for myasthenia, and she started a pacing program with a psychologist, and she did return to work, albeit not full-time, at about 6 weeks. And that's sort of the approach that was taken in this case, because what she did have, while she did have long COVID, is a pre-existing illness. I'm almost finished. And vaccination, long COVID, COVID vaccination can decrease your risk of long COVID because it prevents hospitalisation, and hospitalisation is a risk factor for long COVID. If you've got long COVID, vaccination can improve or have no effect. So in a study, it was found that around about 16% of people actually who had long COVID and were vaccinated had improvements in their long COVID symptoms. Most people had no changes, and 21% had a sort of worsening of their post-injection syndrome for about 2 weeks. Remember that contracting COVID gives you immunity for 6 months, so people don't need to be vaccinated for 6 months. One thing you can consider is there was a randomized controlled study comparing metformin, an anti-helmintic medication that's just escaping me at the moment, and fluoxetine, to see whether they prevented long COVID. And metformin at 500 BD for 2 weeks did decrease the incidence of long COVID by 41% in that population. So you could trial low-dose metformin for people who are appropriate. The use of antivirals is very important, particularly for those over 70 or those 50 in risk factors, or First Nations people over 30. It did decrease the strains with Delta and Omicron to a lesser extent. It's not clear how effective it is for the latter strains, so you might weigh that up. There's been, you can use molnupiravir if you can't take Paxlovid, but it only seems to help those who are not hospitalised with mild disease. Remdesivir can prevent hospitalisations, but only used in hospital because it's an infusion, unless you can do that in general practice. But it's only for high-risk patients. And for those, not suitable, there was some studies with monoclonal antibodies, but they're not that effective. So I'd like to finish there, and I'd like to thank you very much for inviting me, and I'm happy to answer any questions.
Yeah, thank you. I've got one question online already, Stephen. You mentioned that if someone may have long COVID, you give them a vaccine, as I read it, but what about someone who's had a vaccine only, never had COVID? Does the vaccine cause long COVID?
No, the vaccine doesn't cause long COVID, but the vaccine can cause vaccine responses, I guess that they've got to be dealt with as a side effect of immunisation. The N-on-1 study is not blinded, that's correct. Its validity, the validity of his findings, they're sort of low level, but for a while, Bond University and I think the University of Queensland were collecting N-on-1 trials from general practitioners and putting them together and then publishing them as a group. And I think that as a multiple case series is about level 2 to 3 evidence, which is reasonable.
Yeah, thank you. We've thank you very much for your time, and sorry you couldn't be here, but we appreciate the circumstances. So thank you very much, and we'll probably ask you to do some work with some of the questions online if you're happy to talk to Andrew and talk.
Yeah, I'm very happy to
Stasia.
do
Yeah,
that.
thank you. So we've got to keep our breaks and our time online. So thank you very much. Have a good weekend, and
Thank you.